everyone. In this video, we are going to learn about perineal tears and their repair. It is a very common problem seen during the childbirth. Think of childbirth like passing a large object through a flexible ring. If the ring stretches slowly and gently, it stays intact. But if the stretching happens too fast or too forcefully, the ring may tear. Similarly, during vaginal delivery, the perineum. It is the tissue between the vagina and the anus. It will be stretching slowly to allow the baby to come out. But if this stretching is sudden or excessive, perineal tear occurs. As future nurses and midwives, you play a key role in prevention, early detection, care, and emotional support of women with perineal injuries. Objectives: by the end of session, you should be able to understand what the perineum is and what perineal tears are, identify different types of perineal tears, recognize risk factors, symptoms, and complications, and learn how perineal tears are assessed, prevented, and managed. Understand your nursing responsibility in care and follow up. Introduction: perineum in female is a space between the frenulum, labiorum, pudendii, and anus. Okay, it is the space between the vagina and the anus. The exact point is the frenulum, labiorum, pudendii, and anus. So laceration, what is laceration in perineum, is a result of overstretching or too rapid stretching of tissues, especially if they are poorly extensile or rigid. So let us clarify some important terms. Okay, perineum. In females, the perineum is the area between the vaginal opening and the anus. You can imagine it like a soft bridge supporting the childbirth. Laceration. A laceration means tear in the soft tissue caused by excessive or rapid stretching, similar to how overstretched elastic may snap. And episiotomy. Episiotomy is a planned surgical cut given to enlarge the vaginal opening. Okay, unlike the tears, it is controlled, but today we know it should not be used routinely. Okay, perineal injuries are more common in primigravida than multigravida women. Scope of the problem: perineal tear is the most common obstetric injury. Statistics show that about 60% of the women experience perineal injury after vaginal delivery, and 91% of the women report at least one symptom even after 8 weeks of delivery, and around 1000 women per day require perineal repair. So this tells us that perineal injury is not a small issue. It is a major women's health concern affecting physical, emotional, and social well-being. So this is the RCOG classification of perineal tears. The Royal College of Obstetricians and Gynecologists, that is RCOG, classifies perineal tears into 4 degrees. So you can think of this like a layers of clothing. Okay, the first degree means only the skin and the vaginal mucosa, that is like a scratch on a surface. The second degree is skin and the perineal muscle, like tearing the fabric and the inner lining. Okay. And the third degree involves the anal sphincter muscles. In the third degree, we have subtypes. That is 3A is less than 50% anal sphincter, 3B is more than 50% of the anal sphincter, and 3C is both external and internal anal sphincter. And the fourth degree extends into rectal mucosa, and this is the most severe tear. So the third and fourth degree tears are together called as OASI, which means obstetric anal sphincter injuries. So the third degree and the fourth degree perineal tear comes under the classification called as obstetric anal sphincter injuries. While the first and the second can be repaired very easily, the third and fourth degree requires extensive repair. Okay. We'll move on to the visual guide to the tears. So if you can see here, this is the first degree vaginal mucosal tone. Okay. So this is the vagina. In the here only the skin is involving. This is the second degree perineal where the muscles are involved. The dots are the muscles. Okay, perineal muscles are involved. If you see in the third degree, so this the white layer is the anal sphincter. Only half is involved. Okay, part of the anal sphincter is got torn here. But if you see here, including the anal sphincter, there is a layer under that. That's the rectal mucosa. So that is also involved. So that is the severe form of perineal tear. So you should be clearly seeing it. If you don't see it clearly now, you'll miss it clinically. Okay, so you have to see it clearly in the picture now. Okay. So again, this also shows the perineal injuries. Okay, so this is involving only the skin first degree, the second degree it's involving the muscles here, and it involves, if you see, this is the anal sphincter. It is not completely, anal sphincter is not completely, but a part of the anal sphincter is torn here, so that's the third degree. But if you see here, this anal sphincter is completely open. So if you put an finger inside the anal sphincter and ask some patient to squeeze, you will not feel the puckering here. The anal sphincter will not hold your finger. Okay, so that is the fourth degree of the perineal tear, which is shown in the picture here also detailing. Okay, we'll move on to the risk factors for the perineal tears. First is non-obstetric causes. It is done by rape, molestation, falls, road traffic accidents, and bullhorn injuries. And then the fetal factors: large baby, breech or abnormal position, shoulder dystocia, precipitate labor, and instrumental delivery. Instrumental delivery in sense like outlet forceps or mid forceps, low forceps, or any vacuum delivery. So all that requires handling of the perineum. Perineum is already soft during the labor, but if you put your hand and if you put going to introduce more and more instruments, it's going to cause definitely injury to the rectal vaginal mucosa. The next one is the maternal factors. The reasons, the risk factors are primary gravida, previous perineal tear, poor second stage management, midline episiotomy, excess oxytocin, and epidural analgesia. Okay, so these are the risk factors of the perineal tear. And clinical presentations and complications: immediate symptoms are postpartum hemorrhage, severe perineal pain, hematoma, urinary retention, and urinary or fecal incontinence. Delayed complications are infection and abscess, dyspareunia, uterovaginal prolapse, rectovaginal fistula, psychological trauma, and postpartum depression. So as a nurse, you should remember that pain is not the only problem here. You should also see the patient has the dignity of the woman is affected, and also the mental health of the woman is got affected. So all this should be noted in the signs and symptoms of the mother. Okay, the next is assessment and examination protocol. Patient positioning. So the patient should be positioned in extended lithotomy position. So there should be bright light and good exposure. Okay, extended lithotomy position and bright light and good exposure for you to assess the perineal tear, how extent, what degree is the perineal tear occurred. And systematic examination: examine the clitoris to anus. Okay, completely you have to examine, look for pair paraclitoral, paravaginal, pararectal tears. Okay, and also in the anal sphincter assessment, you have to ask for the consent. Okay, rectal examination consent should be obtained. Ask the patient to squeeze the finger, and loss of puckering. Okay, the anal sphincter to hold should hold your finger there. Okay, loss of puckering suggests that there is sphincter injury. So if there is persistent postpartum hemorrhage despite a contracted uterus, you should suspect for perineal tear. Okay. And so while doing the anal sphincter assessment, you have to insert your index finger into the rectum and ask the patient to squeeze. So damaged EAS means external anal sphincter. Hence retract backwards towards the ischiorectal fossa. So if this is not happens, then there is you can conclude that there is some injury to the anal sphincter muscles. Okay. Prevention strategies. Okay, so in prevention strategies we have antenatal prevention, postnatal prevention, and intranatal prevention. In antenatal, how will you prevent? Okay, antenatal perineal massage should be given. Identify the high risk mother. Okay, and manage obesity and GDM. Okay, GDM gives give rise to a large big baby. So you have to manage the GDM and give the insulin to the mother. Okay, and early planning of the mode of delivery. Educate the mother on the modifiable risk. In postnatal prevention, proper inter-pregnancy spacing should be happening so that the muscle contracts well and again relaxes. Okay, and give time for the contraction and give time for the muscle to regain its strength. Okay, and encourage proper perineal hygiene and proper antibiotics and analgesics after delivery. So in intranatal, how will you prevent the perineal teariness? Intranatal period is the most important period where you should be actively giving care. Okay, to prevent perineal tear injury. So we have a mnemonic which denotes the set of rules. Okay, set of policies you have to follow to prevent intranatal perineal tear injury. So mnemonic is safe passages. For S stands for start perineal massage at 36 weeks. A stands for alleviate fear and anxiety. F stands for facilitate occipito anterior position. Okay, so occipito anterior means the occiput of the baby lies on the front of the perineal, uh, front of the pelvic bone. Okay, that is in the symphysis pubis, at the sides of the symphysis pubis, either right or the left side. Okay, so yeah, the occiput has to come in front only, then the head can be delivered. So if the occiput lies in the transverse towards the later, occiput lies in the posterior, that is at the back, the rotation takes time when comparing to the anterior position. So this time also gives risk for the perineal injury to happen. Okay, so we always facilitate occipito anterior position. Okay, and E stands for eliminate midline episiotomy. P plays a warm compress in late second stage. A adduct the thighs at delivery, that is 90 degrees, and S straighten the legs after delivery. S stop sorry, support the perineum. A aim lateral if the episiotomy is needed. G. Go slow, control the head, deliver after contraction. E. Excel at operative delivery. It means you should be skilled enough and you should have a adequate experience to put a low forceps or outlet forceps or introducing a vacuum. You should be skilled enough and you have adequate experience. That's the key. Excel at operative delivery. And S for superb repair technique. So when you do the repair technique, there should not be the aim should be achieved. Okay, there should be proper closure as well as proper hemostasis. Next we'll move on to the management. So in principles of the management, the key principles are early recognition and correct classification, adequate analgesia and lightening, combined vaginal and rectal examination. Immediate repair is better than delayed repair. So why immediate repair we need? It reduces bleeding, it reduces pain, it prevents infection and helps early breastfeeding and bonding. So if you have any doubt in identifying this kind of perineal tear or the degree or the extent, you can always ask for a second opinion. Management of the perineal tears. So the repair site is first and second degree, can be done in labor ward. Okay, if the first and second degree tear, it can be done in labor ward. The third and fourth degree, it should be taken to operation theatre within 24 hours, and there should be repair should be done. The suture material used is Vicryl or PDS for sphincter repair, and continuous suturing reduces pain. And post-operative care, antibiotics, laxatives. Postoperative care, broad spectrum antibiotics, laxatives, sitz bath, and pelvic floor exercise for 6 to 12 weeks should be advised for the mother. In future pregnancies, elective LSCS should be advised for the woman with the previous obstetric anal sphincter injuries. Okay. Medico-legal implications. Creating a tear is not a negligence, but missing a tear is negligence. So the important points are rectal examination before and after repair is mandatory, and a proper documentation is essential. Counseling and follow-up and prevention is very, very important. So one thing you have to remember is what is not documented is considered not done. So whatever you have done should be documented. Conclusion. To conclude, perineal tears are common, especially in primary gravida. Mismanaged second stage is the main cause. Third and fourth degree tears must always be ruled out. Immediate repair gives better outcome. Counseling, follow-up and nursing care are crucial. As nurses, your eyes, hands and compassion can prevent lifelong suffering in women. Okay. Thank you all. I hope you gained some knowledge regarding these perineal tears. We saw the introduction, the objectives, understanding the key definitions like what is perineum, laceration and episiotomy, the scope of the problem, and the Royal College's obstetrician and gynecologist classification of the perineal tear injuries, that is 4 degrees, and I showed you the visual guide, and we saw the risk factors, what are the signs and symptoms, assessment and examination and prevention, the antenatal, intranatal and postnatal prevention and management. In management, we saw the principles and what the suture material, what is the repairing site and post-operative care and medico-legal implications. So thank you all.